the theme that I want you to keep in mind when I'm talking is about building systems of care that manage multiple chronic conditions and manage people with multiple comorbidities. The work that I've done over the last 20 or 30 years, it has moved towards that kind of system building, but often teams need to start with a particular disease to build the infrastructure that can manage multiple chronic condition needs, as well as preventive, primary and secondary preventive care needs. So we know, when we look at the model that Rob presented earlier, we have our larger system here, and the care models are what you're going to be building, the integrated care models. Part of those models will be care pathways, disease-specific possibly, and certainly disease-specific guidelines. But in the past, we typically started with guidelines and then tried to build the system out. And that doesn't work well because of the obvious comorbidities that patients have. So what we're really talking about is building down in, building a larger system with infrastructure that can manage multiple chronic conditions. Our current system came out of the First and Second World Wars, where we were reactive. The orientation was rescue the soldier, repair the soldier, return the soldier to battle. And that acute care system still does a great job of managing short-term illness, injuries, those sorts of things. But what we have to build now is this system of people that need long-term care, people that will have chronic conditions for the rest of their lives that will become progressive over time. And so, as I said before, we often, in the work that I've done across the US and in Canada, we started with diabetes because it's an odd thing to say, but it's kind of the perfect disease to do integration work because of the comorbidities and where it touches all points of the system. So keep that theme in mind. I'm talking about building a system of care for all chronic condition, but we're going to talk about diabetes as a starting point for that. You saw lots of diabetes data today, and so this is just more of that. I'm not going to spend too much time on this slide, but suffice to say that patients don't come nicely packaged just with diabetes. You saw earlier, 90% have other comorbidities and serious comorbidities, and many of these people with their comorbidities need intensive clinical care as well as self-management support. And I'm going to keep emphasizing the self-management support piece. So in the 5 steps that Rob presented earlier, our second step was about segmenting the population. And how do we go about doing that? There's lots of different ways to segment the diabetes population. You could do it by A1Cs. You could use multiple indicators like A1Cs, cholesterol, blood pressure, presence of end-stage conditions like kidney disease, neuropathy. You can look at age and number of high-risk chronic conditions across the population and segment them that way. You can also look at confidence in managing their health. So I'll just quickly show you how those would look in the risk pyramid that Rob also presented earlier in the session. So if we want to do it by A1C control, here's one way of thinking of the population. The healthier patients at the bottom with pre-diabetes or well-controlled diabetes, the people with rising risk who have poor control between 7.6 and 9% for the hemoglobin A1Cs, perhaps the high-risk folks that are uncontrolled with multiple comorbidities, and the extremely complex with end-stage complications, lower extremity amputations, end-stage renal disease, blindness, so on and so forth. And keep in mind, as you go up that pyramid, you also have equity issues, you have marginalization issues coming along with that medical complexity. So we also have to keep that equity focus on the pyramid. Here, people, if you look, I know one particular practice in Victoria, BC, all the providers on Victoria Island tracked the people that had all their A1Cs, blood pressure, and cholesterols in control. So they segmented the population that way. All indicators in good control were patients that were relatively healthy. Rising risk, one indicator was out of control. high risk, all three were out of control, and complicated patients had poor ABCs for 5 or more years. So again, here we can look at the social determinants and as well as control issues. So if you take people's things like A1C, their blood sugars, other clinical indicators, and start looking at their overall health, people that have stable income and housing, could be the healthier patients at the bottom, possibly people with changing life situations or have become marginalized or have control issues. The higher risk people are folks with poor health literacy, low income, low education, poor access to the system, as well as poor clinical control. And then clearly the complex could be the most deprived people coupled with uncontrolled diabetes. Now there's going to be mix and matches within those various strata. But it's just to give you a sense of how you can start thinking of the population and how do you start stratifying them so that you can target interventions appropriately, because obviously an intervention for people that have good overall health, stable income and housing is not going to look the same as an intervention for people who are most deprived and coupled with uncontrolled diabetes. But when we think about self-management support, and the goal of self-management support is to increase patient self-efficacy or patient confidence. Work done by Wasson et al. Out in Dartmouth, they actually took practices and had the providers measure the patient's confidence in managing their health. And I won't go into the details of that, but it's a fairly simple question that you can ask patients. And when he coupled that with the control of their chronic condition, in this case it was diabetes, he produced this grid. So people that were highly confident in managing their care and had good clinical control basically just needed good, usual primary care. People with poor clinical control but high confidence needed some tweaking. So they needed to be doing action planning, goal setting to get their control under better control. People with low self-confidence but good clinical control also needed action planning just to boost their confidence and make sure they could continue to take care of their chronic condition. And then obviously in the red section there, people with low self-confidence and poor clinical control typically needed interdisciplinary team care. Multiple providers working with them not only to improve clinical care, but to boost that confidence level in managing their care. So that's another unique way of thinking about stratifying. So in these last few slides, what I want to do is emphasize that we have to build a generic system of care that manages all chronic conditions. And so what I'm going to do is go through the different community partners and go from the generic. So in this case, you see primary care and you see the generic disease registries are needed. If we're looking at diabetes, it's all patients coded with 250.XX in the EMR. They may want to also add what are the comorbidities that these patients have. Generic, all people without a recent visit. In the case of diabetes, you'd be bringing patients in with high blood sugars. So you're using electronics to do recall systems for patients out of control. The visits need to be different. Our chronic care visits need to be longer. They need to visit medications on a regular basis. They need to, in the case of diabetes, foot exams need to happen, renal screening, A1Cs, LDLs, and self-management support. And there's some data in the PAM scores that would help you with confidence. But those planned visits would have a similar structure across chronic conditions. Same thing again, prevention. Prevention should be part of every chronic condition visit. In this case, you want to make sure patients with diabetes have pneumococcal vaccines, COVID vaccines. Someone's done a social determinant health assessment so that they can hopefully prevent some of the impact on outcomes that SDHs have. Again, self-management and cancer screenings. All of these things are what need to happen at that visit. There are provincial supports, again, for doing chronic disease systems. There's an Ontario self-management program that trains staff in brief action planning and provides chronic disease self-management programs for patients to come and learn how to manage their chronic conditions. And then we have national programs like the ECHO programs. So again, across all of this, we're talking about integration. So while primary care is doing all of that, they need to be integrated with the hospital. And from the hospital standpoint, they would be providing coordinated care during inpatient stays. So some unique sort of internal integration is having joint multidisciplinary assessments at the bedside. So rather than having an endo come in one day, a nephrologist come in the next day, a chronic condition specialist the next day, everyone's at the end of the bed talking to each other about how to manage that patient. When we talk about integration outside of the hospital, we need to have discharge summaries that are attached directly to the primary care practice or wherever the patient's being discharged to, but typically primary care, and that the hospital schedules a visit inside the primary care schedule to make sure that that patient is seen and the discharge summary is located in that scheduled visit. For acute exacerbations, again, the hospital needs to do some of the work that primary care would be doing to make sure that there's partnership there. So if people are coming in with high or low blood sugar events, make sure they're referred to the Diabetes Education Center. All of this is coordinated with the PCP. And again, more integration work, prevention. So if I come into the EMR, or excuse me, if I come into the ER with a high blood sugar, someone checks to see if I've had my diabetes vaccinations, checks to see if I've had an annual foot, renal, or eye screening, checks my cancer screenings. And all of that information, whatever the hospital does for me at that point, is sent back to the PCP EMR. Specialists, this has been a tough nut to crack for everyone for the past few decades, but we have to engage specialists in population health management. Any specialist should be looking at their panel of patients that they see from a registry perspective. So make sure that the endocrinologist has not only registries for thyroid issues and other endocrinology problems, but they have a diabetes registry, and that their referral agreements with primary care are very structured. That is, they get exactly the data they need from primary care, and they send back the data and recommendations that primary care needs through not only electronic mechanisms, but referral agreements that make sure that they both get what they need so that the patient can be better managed. Another thing I've seen is joint visits by special Washington State. It was incredibly successful, where an endocrinologist would visit with the primary care practice for specific patients that the practice identified. The PC team would be trained in evidence-based care, and the nurses were trained in self-management support for patients. So there's lots of integration work we can do with specialty, and I think that's got to be a big part of this focus also. No matter where the patient touches the system, they need to receive some level of education and self-management support. And we have no shortage of provincial supports for people to be trained in very simple self-management support techniques that are patient-driven. So it's one thing to teach patients about how to take care of their diabetes and then tell them they need to eat and exercise more. It's another thing to ask the patient, what is it you want to work on in terms of managing your health, and then helping them set an action plan that they can achieve and build that confidence. Because once they're confident, there's a causal link between patient self-confidence and clinical outcomes. Home care. I think there's a great examples already in the province of integrated patient care teams or integrated primary care teams, as sometimes they're called, where home care is being used as care coordinators to work with primary care to manage patients that are rising risk and at risk of complexity. So again, more integration across systems.